afternoon, and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually, please enter your question into the Q&A chat. Also, a link to the event survey will be shared with you at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Rahul Patel. Dr. Patel is a PGY-3 internal medicine resident here at Northeast Georgia Health System. He completed his medical degree at New York Institute of Technology College of Medicine. Dr. Patel will be working as an academic hospitalist after graduating residency and then pursuing a GI fellowship as the next step in his career. Join me in welcoming Dr. Patel.
Good afternoon, everyone. Thank you for joining me. So my topic for Grand Rounds today will be AI and GI shaping the future of gastroenterology. My disclosures, I don't have any financial interest or arrangements for this presentation. The learning objectives for today is to recognize the uses of AI as it applies to the field of gastroenterology, measure the benefits of AI compared to the current practices that we have, and to debate the role of AI and its role in medicine in general. So a little bit of what is AI. Ultimately, it encompasses disciplines such as machine learning and deep learning, using large data sets to recognize patterns of interaction between variables. And that's just a fancy way of basically saying to take what's known data set and then give the allowed function and algorithms to take its place, and then apply that to new data and hopefully lead to new advances in technology and medicine in general. So AI in gastroenterology, the first global AI in gastroenterology and endoscopy summit was actually held in Washington, D.C. 5 years ago. And this consortium was gathered because they recognized the importance of a close multidisciplinary collaboration between gastroenterologists, the industry, which is the AI, the engineers and everybody, and then the regulatory institutions such as the FDA to come together in development and application of these new technologies in the clinical setting. And if you see the graph right there, AI, basically you input the data, which is, you can have lab blood work, administrative data, biometrics. You take that, and you can also take unstructured data, which is basically your images, and then your text, so our articles and everything. You take all the input data, you put it into this data annotation, which basically annotates all the outcomes, the measurements, the prognosis of all the data. You put it through the AI machine learning, which the model will basically take that data, apply its algorithm, and try to predict make its own annotation and predictions and data. And now you can take this AI application that they did and apply it to multiple different things. You can apply it to endoscopy, you can apply it to histology, you can apply it to taking these complex articles over 10, 20 pages and make a summarized clinical detail. And then you can also use this AI models to see the therapeutic response of medications, hopefully come up with better and more improved drugs with less side effects. So, AI has been around for a while, and it's just improving every day. So the outline for today's presentation will be going from the upper GI tract, lower GI tract, talking about IBD diseases as well, hepatobiliary system, and then pancreatic diseases. And this is a graph to show machine learning to see all that's available in all these diagnoses. So starting with the upper GI tract. There's several areas of interest for this specific GI tract because there's multiple detection of lesions that occur, such as the identification of dysplasia and neoplasia on Barrett's esophagus, finding esophageal squamous cell carcinomas, gastric cancers, H. pylori testing as well. And then for these detection of lesions, the most important thing is the histopathologic analysis, as that's the gold standard for establishing the diagnosis. And as such, it's important for endoscopists that are obtaining these biopsies to make sure they collect the biopsies from the specific locations that harbor the actual malignancy, instead of, maybe not getting the malignant portion and maybe getting a non-dysplastic portion and incorrectly saying there's no cancer when there could potentially be. And then that's where, AI can help us with that. So the Barrett's esophagus, just a little to tell you about it. Just the lining of esophagus is damaged. Most commonly, it's in the setting of GERD and acid reflux. And then when the healing happens after this initial damage, the new cells are actually dysplastic and change to some of the intestinal cells. So squamous cells become columnar. And this leads to increased risk of developing esophageal adenocarcinoma. And currently, the detection rate for Barrett's esophagus with endoscopy is generally considered to be about 80% when using just standard endoscopy, no AI or any other adjustments made. And multiple studies have shown that inexperienced endoscopists, which were in those studies defined as less than 5 years of practice and less than 1,000 cases of endoscopy, they have missed diagnosis of early esophageal cancer as they present as small lesions and as such are easily missed by inexperienced eyes. So coming to the AI portion, there was multiple algorithms, but there's one algorithm that was created from over 1,000 images. So they put all those 1,000 images into the data set, had the AI algorithm run through it, and it was focusing mostly on only Barrett's esophagus neoplasias. So what they found was, in general, this model was able to discern between the normal and the dysplastic neoplastic images with an accuracy of at least 89.9%, performing better than non-expert endoscopists. And as you remember from the last slide, you saw that usually they would get about 80% of these lesions. And if you look at right here on these images, this right here is the AI-guided imaging. It's basically showing you this portion, according to all the data and algorithm that's put in, that this portion seems to have some type of neoplasia. And then here as well, it's also kind of showing the endoscopist like this is an area that we need to, look at and possibly take a biopsy from that area. And as such, the model was able to detect the optimal biopsy site in up to 97% of patients. So this allows the endoscopist to get the biopsies from that lesion, and that way that's basically 97% accuracy rate of that is where the neoplasia was, and they can get accurate diagnoses from that. So that's the Barrett's esophagus improvements that AI have made in multiple studies. Another major thing at GI tract, upper GI tract, is squamous cell carcinoma. This is most commonly caused with alcohol consumption and smoking, and this has a worse prognosis than adenocarcinoma. Adenocarcinoma has about a 22-month prognosis if caught at a later stage, and then squamous cell carcinoma has about 27 months. And the most important thing for squamous cell carcinoma is predicting the depth of the invasion, as that allows the endoscopist and other physicians to basically make a better treatment plan, and especially since the depth of the invasion of the cancer has a very reliable relationship with the rate of lymph node metastasis. So if it's caught at an earlier stage, all you need is endoscopic resection, and that, and then look at the histology, and it usually has a clean margins. And sometimes, if it's too deep, it's a possibility of requiring esophagectomy, which of course is a pretty invasive procedure and much for more advanced malignancies. So if you look here, the AI system that was developed for squamous cell carcinoma is actually very effective in evaluating the invasion of the depth of superficial esophageal squamous cell carcinoma in these video images. And it's actually very comparable and actually even better than expert endoscopists. The accuracies were between 89 to 91% for the depth, and then 70 to 90% for the sensitivity. So if you see right here, the AI is outlining where they think you have a squamous cell carcinoma, and it's actually helping the endoscopist to look at that region. And I have not put the slide here, but there's also where it can predict the depth of it depending on all the data, all the previous data that's been put into the data sets to see, according to the algorithm, if it appears to be like this, the depth might be into the mucosal layer or, deeper. So, this is also improving detection of squamous cell carcinoma and leading to hopefully earlier catches of the malignancy and better patient outcomes. Another application in H. pylori. Currently, H. pylori is a known risk factor for developing peptic ulcer disease and gastric cancer. And gastric cancer is one of the 5 most common cancer-related diagnoses globally and the 3rd leading cause of death in cancer patients. Currently, diagnosis for H. pylori relies on stool or breath testing and histopathology from biopsies taken by endoscopists. According to 2 studies, the mean accuracy of endoscopists for detecting currently infected H. pylori was between 79 and 79.4%. And this is because when endoscopists go in, they take what they call random biopsy. Usually they go in because the patient has GI bleed, peptic ulcer disease, and they want to rule out H. pylori as a cause. So they take random biopsies. So for that, there was a model employed that used over 30,000 endoscopic images employed during live endoscopy and was actually able to predict the presence of H. pylori infection with a sensitivity of 89% and a specificity of 87%. So if you look at this graph here, the AI is pointing out these specific regions as high likelihood of having the H. pylori bacteria, and it takes these images, kind of zooms in for endoscopists to look at as well, because of course AI is there to assist the physician, not to replace them in endoscopy. So they would look at the images and kind of guide the endoscopist to, like, this is a special interest to look at, and those would be optimal biopsy sites to get. And those have increased, according to the studies, they have increased the rates from about 79% to about 89%, so about 10% increase, which is pretty substantial. And then, on GI bleeds, which are very common that we see in the hospital. So not only does it help with endoscopy, it also helps with data acquisition prior to endoscopies. So for GI bleeds, there are several scoring systems that exist to predict the clinical risk of GI bleeds. The HAS-BLED has the best performance to predict the major bleeding events for patients on anticoagulation. So if you look right there, there's a HAS-BLED risk score, and if you have a greater than 4 score, once you add all up, you have a high risk, about 4% chance per year of getting a GI bleed if you're on the anticoagulation. So machine learning algorithm was analyzing data from 300,000 patients, and that was compared to this HAS-BLED risk model. And they found that the machine learning algorithm actually performs superiorly to the HAS-BLED model in predicting GI bleeds at 6 and 12 months. So the HAS-BLED achieved a AUC of 0.61 in 6-month bleeding risk, and then 0.6 for 12 months. And then with the algorithm, it actually achieved the AUC of 0.68 for 6 months and 0.67 for 12 months. So it was more accurately able to identify patients that were higher risk. So there could be, more improved discussion between patient and physicians about their risk profile, and also to help physicians keep their risk profile get more detailed data on their risk. And then, that was before GI bleeds. During endoscopy, there's a lot of AI uses in that as well. So during endoscopy, AI can help identify endoscopic characteristics of hemorrhage, such as determining the Forrest classification, which is used for peptic ulcer disease, for peptic ulcers, and determine the management needed for the patients. So one of the models used the endoscopic still images from 1,600 patients with peptic ulcer bleeding, and then machine deep learning was able to identify those bleeds seen with sensitivity of 94% and specificity of 92%. And as you can see, right there with the Forrest classification, it's showing like active, recent, and lesions without active hemorrhaging. And of course, it tells you the bleeding risk of all these ulcers, going from almost 60 to 100% of rebleed risk to less chance. And the AI system was able to help classify these ulcers and basically lead to prognostic data as well. It was able to use all the data sets to determine if the patient was stable for discharge, was his require monitoring on a regular floor, or they might need ICU if they have a high risk of bleeding. So AI, helping not just endoscopists, but hospitalists and intensivists as well. So now we can move on to the lower GI tract. And for this, most societies, they recommend counseling the patients that undergoing colonoscopy. There's always a chance of missing. And from all the data, they've said about miss rate of about 2.1 to 6% for significant polyps and cancers. And of course, this miss rate can lead to malignancy being found at more advanced stage and leading to worse patient outcomes. So it's a hot topic to make sure that we don't miss any significant polyps, which they can if there's poor prep, or if the endoscopist can also, of course, human error comes in effect as well. So these miss rates are happening. So some AI models have actually, using the polyp detection, have found accuracies of 96.4%, with sensitivity of 99.7 and then specificity of up to 93.7. So as you can see here, as the endoscopist is going through the colonoscopy, the AI is, some of these are obvious, but it's just making sure that there's no polyps missed. It's pointing out the polyps. And then another aspect that AI is also helping is to decide if these polyps that they do find, to classify them, to determine if they're, neoplastic, non-neoplastic, high possibility of malignancy or not. So this will help with surveillance schedules as well, if they need to get repeat colonoscopies in 3 years or 5 years, to reduce, the costs as well, doing repeated colonoscopies. And out of all these, the best AI model was actually able to achieve an accuracy of 96.4% in classifying these polyps, which is, very, very good. So right here, it's able to analyze this polyp, and it's able to basically say it's a high probability of, malignancy was looking at this one, and they say, it's probably a low probability. And then, of course, it's all goes in, this is supporting the endoscopist to decide if they want to resect it, send it for histology, and then, like I said, if they need to do earlier or can wait or do earlier colonoscopies, like repeat colonoscopies, or wait. So there was that. And then next we could go on to inflammatory bowel disease. So diagnosis of inflammatory bowel disease is actually a big challenge for physicians. They have to use a lot of clinical data, biochemical data, use images, radiology, and then you use endoscopy to make the correct diagnosis. And then you use endoscopy as a cornerstone of follow-up of these patients that are diagnosed with Crohn's and ulcerative colitis. So in a retrospective study done, an accurate diagnosis of IBD with colonoscopy was demonstrated in about 89% of cases. And then in 7% of the cases that were done, the diagnosis was undetermined. And then in 4%, there was an error in the diagnosis. And this can happen because when there's when there's too much inflammation, even with the histology that's obtained with the biopsy, it's difficult to tell if it's Crohn's, if it's ulcerative colitis, if it's a mixed picture. So it's very difficult to make the accurate diagnosis and deciding which treatment to pursue. So with AI, there was a model called a red density model. It was able to score the disease activity in ulcerative colitis patients using a redness map and using vascular pattern recognition. And then this is taking all that data from all these other still images and applying it to other patients to see, using the recognition, is it more likely to be ulcerative colitis, was the optimal biopsy spot to get the correct diagnosis. And this helps gastroenterologists and other providers determine the appropriate treatment plans, as well as determining the risk of a relapsing of flare-ups as well. So with this model, the AI is used in all three regions, actually. The AI is able to help get the AI guided endoscopy, just find the lesions, get the optimal biopsy sites, and then it can also get the histology. The AI will, like I said, use the previous data. If they look at the data and say it's more likely ulcerative colitis, it's more likely Crohn's, from the previous data. And then it's actually also able to help predict the outcomes and responses to therapy. Let's say you have a patient that had similar findings. They can use data from previous patient that might have similar findings, see how they responded to the steroids, whatever medication treatment, and they can help predict the response therapy with that. And of course, it's also used in the radiology to determine it's most severe here, and like the Crohn's or something flare-up is most severe there. So it's the AI is used basically on all stages for IBD, and it's improved a lot of the diagnoses in those studies for those patients that were studied. And then we'll move on to the hepatobiliary system. Now, many of the hepatobiliary diseases are typically diagnosed using clinical data, imaging, and then biopsies to confirm the diagnosis. As you can see here, AI is able to help with all of these steps. The data acquisition, looking at the CT scans, MRIs, looking at the histology, looking at the ultrasound, hepatic ultrasound, rapid coronary ultrasound. And then they take all this data and then put it into the image databases. And then they take the data images and then put it to the algorithm. So take all the data, they process it, put it in running the extraction for the data, supervised versus unsupervised, and then they can compute is based on the imaging, based on the biopsy, is it malignant, benign, et cetera. And then the other clinical applications, of course, taking the biomarkers of, let's say, taking the biomarkers from imaging or from the histology and leading to diagnoses as well. So there are multiple AI models that are currently available to improve the detection of the steatosis, fibrosis, cirrhosis using all this data. I want to just talk about MASH, which is the leading cause of cirrhosis currently. An AI ultrasound-based AI program was actually able to detect over 90% of the patients correctly. Typically, unassisted ultrasound is able to detect about 77% of the time. So let's say, you get the data, you get the report back saying no, no findings of MASH or found. So 77% might have that, but with the AI data, it can go up to 90%, and then after that, you can get CT MRI scans to, further extend the disease. So it's just one of the applications that I wanted to discuss how, even ultrasound, it can improve about 13% compared to non-assisted ultrasound. So now the pancreatic diseases. So as we know, the pancreatic cancer is projected to become the second leading cause of cancer deaths in the U.S. by 2030. And this is mainly because most patients are diagnosed at an advanced stage and where treatment options are more limited. And then depending on some of the studies, nearly 70% of the patients don't survive past the first year because it's advanced. It's found pretty late. So there was one AI model that was created on an extensive data set from over 3,000 patients taking the CT scans, and looking at them, they were able to correctly classify 88% of CT scans with an AU-ROC of 0.97. And so AU-ROC is basically area under the curve, measures how well a model can discriminate between the classes, such as those that have a disease and those that do not. And a score of 1 is basically perfect. It's able to say you have a disease or not. So 0.97 is almost perfect. So this model was able to classify 88% of those. So basically to help diagnose the pancreatic cancers. And also they found remarkably that this model, when they actually showed like pre-diagnostic CT scans versus the current CT scans, it was actually able to clinically diagnose the cancer, from the images, diagnose that there was cancer there prior to when it was actually clinically diagnosed by physicians by about 3 to 36 months. So it was actually able to say, looking at the previous CT scan, like there was cancer there that was not, detected by the radiologist or anybody. And then, 3 to 36 months after, they get repeat CT scan because it's worsening, and then it's progressed more, and then that's when I clinically diagnosed. The sensitivity for this was a bit lower, 75%, but the AU-ROC curve was 0.91, which is still excellent. So it's still able to say that there's cancer there or not. So these findings were able to highlight the model's potential in detecting early pancreatic cancer, and this can lead to ability to start the treatment at an earlier stage as well, theoretically leading to improved patient outcomes. Okay. So, just going through just rephrasing liver diseases, AI is being able to use the CT imaging, being able to use biopsy results, and all of these data analysis and everything. So it's very beneficial, but there are limitations to it, of course. One of the limitations is most of the current models are labeled data. So the gold standard data that they say in their data sets is only as good as the expert. So if the experts say this is what it's esophageal cancer, and if they make the mistake, then AI is gonna assume that even if it's not esophageal cancer, the AI is going to presume that it is. So it will say basically continue that trend. So there is some false positive rates with AI. So we always have to keep that as a limitation in our minds. And then the clinically applied AI models are internally validated. Ideally, models should be externally validated on diverse cohorts to ensure overfitting is not an issue. So essentially, these AI models are usually, the data set is made from usually maybe one institution where they take all that data, but sometimes, that might be a regional, there might be some regional effects that might not apply to a different region or different patients in a different region. So, right now, most of them are internally validated, but once AI becomes more available, more data sets available, they can be externally validated as well. And then another limitation is majority of the studies, they use still images and high definition images. They use the best images and data to make these algorithms and data sets. So these are not usually applicable to real-time settings, which means sometimes if you're getting a real-time endoscopy, colonoscopy, some of these images might not be able to be used. And if you have imaging from a motion artifact or poor images from outdated equipment, it might not be able to identify the malignancy or the polyp as well, just because it's made from a high definition, and the imaging that you might have at a different institution might be poor. So that's also a limitation that we need to keep in mind when we're using AI. And then I just want to talk a little bit about the financial aspects of AI. It's relatively still, AI, we've been having, so much AI, but it's still relatively new. Some of the models cost about $60,000 just for the purchase of it, and then they might have subscription-based, which is maybe $1,000 a month. And this is one model. It depends on what model you're using for. Are you using it for H. pylori testing? Are you using it for colorectal screening, polyp testing? So I'm sure they all cost different. I don't have all those, but this is one example. And you would have to purchase different models if you want to use it for different diseases, like I just discussed. And currently, there's no direct reimbursement from insurance or Medicare for using AI. So this would be an added expense for the health system or the practice that uses it. And furthermore, there's additional cost with training the staff and the provider in the programs, and then integrating the AI model into the existing workflow. So there's a lot of costs associated with using AI. But however, further cost-benefit analysis needs to be performed to see if the potential lower incidence of malignancy will outweigh the price of the AI models. So let's say if we're able to say the AI is able to catch 13% more of the polyps compared to the inexperienced endoscopist, and let's say it leads to malignancy, the treatment cost for treating that malignancy down the road, it might be more cost-benefit analysis better to invest in this AI system. And of course, it's also better for patient outcomes as well. But financial aspects is everywhere in medicine and the world. So more study needs to be done on that. So the future of AI, the AGA actually recently shared a new draft in the clinical guidelines on using the AI assistance in colonoscopies. And then the guidelines provide evidence and make a conditional recommendation for using the AI-assisted colonoscopies to detect polyps in adults. And this is mostly supported by the fact that there's little to no adverse events from using the AI, and there's no clinically meaningful increase of time needed to conduct the colonoscopies. Now, the final guidelines will be published in March of this year, but they've kind of introduced this into the AGA guidelines. And then this hopefully will lead to new changes in the guidelines, hopefully get FDA approval, and that will hopefully lead to making AI basically hopefully standard practice, and that will allow the insurance and Medicare rate to cover the added expense and reimburse the hospital systems and the physicians that use it for the patients. So the final thoughts I want to just leave you everyone with. For all the benefits and advantages that AI provides us, there's still need for further advancements of the AI models and the uses. there are false positives, false negatives. It's only as good as the data that it was provided. So even though it is better than the unassisted, there's still much room for advancement. And then cost is a significant challenge in being able to provide AI-assisted technologies commercially across the country and the world. And currently, it's only mostly available at the top academic centers that are using it for getting this data and improving the AI systems. But then hopefully soon, like I said, these challenges can be overcome with AI being accepted into guidelines and being hopefully reimbursed by insurances. And this is just my references. These are all the data if you want to go in and look at all the AI data sets that I was talking about. And then a special thanks to Dr. Sharma for helping me with my presentation. And then any questions?
Awesome. Thank you, Dr. Patel. If you're viewing online and have a question, please enter it into the Q&A chat and we'll ask for you. Any questions or comments in the room? Oh, one down here.
Excellent presentation, Dr. Patel. Really enjoyed your view on the AI and the current views of the AI. But I had a question about if there's any advancements in pill endoscopy or capsule endoscopy. Did you find anything about that?
Yes, so there were some advancements in the capsule endoscopies as well. I did not include it in my presentation, but whenever you have right here, so capsule endoscopies, they do have the AI data sets for that as well, where they capture all those images and they're able to, put in the data like I discussed. So when you put those data in there, I didn't really use that much because I was more focusing on colonoscopies and all that. But there are AI uses in capsule endoscopy as well. I can't tell you the data on how much has improved from, current non-AI assisted capsule endoscopy to that. Yeah.
And I might have missed it, but are we doing this at NGHS yet?
No.
No. Okay. Any other questions? Oh, over here.
Hey, Dr. Patel, thank you so much for a great presentation. My question is, I think during this research, did you find any, complications with AI and what the detrimental findings were if AI had diagnosed something wrong? Did things go wrong and what was the probability of that?
So, like I said, there are the kind of limitations. It's only as good as the data or the expert that say this is the data. So some of the things that could go wrong if it's misdiagnosed as if it's a benign polyp and the expert said it's malignant, that can lead to AI also saying that's malignant, and then the endoscopist at that time might, pursue more aggressive actions, and that might lead to, more frequent follow-ups and more testing and everything. So that can increase the costs and, just the patient emotional burden. But there's really no, adverse effects. It's very minimal in the AI use itself, but the data could have some, that's why it needs to be externally validated and have more data sets available. So, more data that you put into the algorithm, the better, it can predict when you use it.
Hey, Rahul, very nice presentation. So I have one question. So do we have any data on the AI model that AI is able to predict how many false positives or distinguish false positives?
When in my research, I did not really focus on the false positives. But, let me look into it, and then I can send you the data. I'm sure there are false positives, depending on, all the data sets that were done, but I don't have the answer for you right now.
Patel, have you, in your research, have you seen anything like, have they used like synthetic data to train these models, like to go around the limitations of the limited data?
So the synthetic data, so when they use the AI models, they usually put in the data itself and using all the models. I do believe there are some models that they added these extra, like you said, the other extra datas that they can give in. But I presume that those will also those would have to be. I think they would have to include, using that data, they would have to basically say if it was from a data set or if they just made this, like you said, synthetic new data, like superimposed or taking data you have and saying, okay, if this is true, can we extrapolate that data and say this is also true? And that might complicate things with the AI algorithm itself, because, algorithm has to basically compute all that. So I did not see any of the references that I saw that they used that, but I can look into it more and get back to you.
Hey, very good presentation, Rahul. And very actually, in future we need AI, and it's going to be incorporated, but now it's too early to say things. But one question, you said colonoscopy. So is it going to help to detect the polyp, or because I know very well radiology and pathology, histopathology, that's very helpful, the AI to detecting, but the colonoscopy during detecting polyps, is it, or I didn't get that, how AI will help during the colonoscopy?
Yes, so currently during colonoscopies, the societies actually say there is a miss rate of 2 to 6%, and that can be from, sometimes you can have kind of poor prep, or colonoscopy prep. Then polyps might be very tiny, where the endoscopist might, when they're going through and doing it, they might miss it, or they might, see multiple polyps, and like, okay, they don't want to take all the polyps, so they might choose one. So like I said, like this, it's kind of obvious, like some of these are pretty big, but if you have tiny, like this one, you can't really even tell. So if you have the tinier polyps, it kind of gives the focus on the endoscopist doing the colonoscopy, saying like, hey, there's something here, just look at it. And sometimes there could be nothing there, but this is kind of hopefully leads to decreased misses. And this model was actually able to increase the polyp detection up to about 96% compared to, this is in addition to just the endoscopist itself looking at it as well. So it's an extra layer of protection from missing.
I think I missed that portion, that's why. Thank you.
Thank you, Dr. Patel.
Thank you.